Well, you can see right off that he's 21st century and I'm 20th century. 25 years ago, I had the privilege of sitting in a conference room having dinner in Bogota when, under the leadership of Dr. Patiño, the Pan American Trauma Society was created. Dr. Patiño was clearly the godfather, and I'm sure that he is proud of his over 2,000 godchildren. And so would the Bogota surgeons, when they head back to Bogota, please give him my best wishes. Almost 45 years ago, I finished my surgical residency at Wayne State University and joined the faculty, where I spent the rest of my time at the Detroit Receiving Hospital. What I'm going to present to you relates to experiences to patients primarily with penetrating gunshot wounds who ended up in the operating room very shortly after arriving in the emergency department following a short pre-hospital trip of about 5 minutes. Over the past 45 years, I've stirred many pots, and I'm going to stir for the first time today a new pot. So for the young people in the audience, pay attention. The question we wanted to answer is, what is the role of plasma in the correction of the coagulation products, and what is the effect of the plasma to red cell ratio on the shock response? The first question we answered by looking at the procoagulants. Fibrinogen is one of the stable factors, and both factor 5 and factor 8 as the labile factors. We looked at both of those because factor 8 is actually a tripartite factor with only one part made in the liver. And we looked at the standard coagulation tests. Despite the many papers that you've read about the plasma to red cell ratio with plasma used to replace procoagulants, the data you're going to look at now is the first report of the actual measurements of procoagulants in this situation. We looked at a group of 32 patients in the operating room. They were studied an average of 3.8 hours after they arrived in the front door. They had a shock time of 47 minutes. By shock time, I mean the systolic pressure was less than 80 millimeters of mercury from the time they hit the front door until the time that the operation finished. We call that phase 1, ED plus OR. This is the resuscitation that was used, the red cells, plasma, and balanced electrolyte solution, and this was the ratio in those 32 patients. We also looked at 53 patients, including 22 of the patients studied in the operating room, in the early postoperative period at an average of 17 hours after they hit the front door. And in these patients, the shock time was 42 minutes, and these are the blood, plasma, and crystalloid given during phase 1, which is operating room plus emergency department. In the operating room, at an average of 3.8 hours after injury, the PT was 3.5, which converts to an INR of 1.3. The PTT was 34, and the thrombin time was 7.9. The fibrinogen was 148, with the normal being 300, and these are the percent activities of factor 5 and factor 8. In the patients studied at an average of 17 hours after injury, you can see that the PT, the PTT, and the thrombin time have improved, and you can see that the fibrinogen is way above coagulopathic levels, as are factor 5 and factor 8. Now, when we looked at the patients who had the Come on, Charlie, don't be so stupid. When we looked at the coagulation times, we showed that the more plasma to red cells, that the ratio caused an improvement. The higher plasma ratio caused an improvement in the PT, PTT, and thrombin time, with highly significant values for the TT and the PT and barely significant for the PTT. Likewise, the higher ratios of the plasma and to red cells improved the fibrinogen, the factor V, and the factor VIII. So there was a clear correlation for both of those effects during operation at an average of 3.8 hours. At an average of 17 hours, most of those correlations were now no longer significant, with the only continuing significant correlation being the amount of the ratio, the plasma to red cell ratio, with the factor V at 17 hours after they hit the front door. When you look at the breakdown of the different ratios, you can see that the PT correlated with the ratio in an inverse manner in a highly significant way. And when you look at the subgroup of patients who had a PT which was above 5, which is an INR of 1.4, that these 5 patients all had a ratio of less than 0.3. Likewise, or 0.25. Likewise, when you look at the patients who had the PTT, which correlated in a highly significant inverse manner with the ratio, you can see that all of the 5 patients who had a PTT, which was over 35, had a ratio which was less than 0.3. And then when you look at the same thing with the TT, again, a highly significant relationship, you can see that all of the 8 patients, or 7 patients that had a TT, which was above 8, had a ratio which was less than 0.31. So based upon, and when we look at the fibrinogen, you can see that all of the patients who had a fibrinogen which was less than 125 had a ratio of less than 0.31. Incidentally, if you have a fibrinogen which is above 125, all of the plasmapheresis studies in the Eastern and Western world show that this is not coagulopathic state. The same is true for the patients with the factor V. All of the patients who had a factor V, all 8 of those patients who had a factor V, which was less than 35%, had a ratio of less than 0.31. And finally, for factor VIII, all of the 6 patients who had a factor VIII level less than 35% of normal during operation had a ratio of less than 0.3. Now, when we look at the patients in the lived and died category from the time of operation, we had 5 patients who died on the table. 4 of these patients, 39 is our computer code name for no palpable pressure, and 200 is our computer code name for unable to feel the pulse. 4 of them had no pulse or pressure. 1 of them had a pressure of 60 and a pulse of 158. These patients were dying on the table. They received a whole lot of red cells and not as much plasma because every line was being used to replace red cells. These patients were bleeding to death from uncontrollable arterial injuries. When you look at the coagulation studies in these patients, you see that indeed the PT was way off, the PTT was way off, and the TT was way off. Likewise, 2 out of the 3 of the procoagulants were in the range where the experts would call coagulopathic. In contrast, when you looked at the patients in the postoperative period, we had 7 deaths None of those deaths were coagulopathic. None of those deaths had abnormal coagulation factors or abnormal coagulation times. And these are patients who were studied an average of 17 hours after they hit the front door. These patients died of other issues. They did not bleed to death. And the same is true for the patients who had the coagulation factors measured at 17 hours and subsequently died. These are all very good levels for factor 1, factor 5, and factor 8. So based upon these data, we concluded that an FFP-RBC ratio of 0.31 restores procoagulants and clotting times to adequate level. We next asked the question, what is the effect of the ratio on the shock insult? And our previous studies have demonstrated that after a severe hemorrhagic shock insult, the patients will enter into a fluid extravasation phase where fluid sequesters in the interstitial space, which we have measured in many of these patients. And as part of that phenomenon, the phase 2 or weight gain period will last an average of about 30 hours in patients with this type of insult. And we looked at in the interstitial space, we looked at the length of the fluid uptake phase, the amount of crystalloid given to maintain vital signs, weight gain, and the degree of hypoalbuminemia, and we correlated it with these three ratios. We demonstrated that in 116 patients who were hypotensive tachycardic and had a shock time of an average of 31 minutes and received an average of 14 red cell units, 855 ml of plasma, and 11.5 ml of crystalloid solution is the group of patients that we're looking at. And this is a quick summary showing that the shock time correlates very, very highly with the hypoalbuminemia, the weight gain, the phase 2 length of the fluid uptake phase, and the amount of crystalloid needed during this phase. The same is true for the amount of red cells, the amount of plasma, and the amount of crystalloid. For the most part, you don't get it here, for the amount of crystalloid correlates very strongly with the indicators of severity of shock insult during the fluid uptake phase. In contrast, the FFP to red cell ratio did not correlate with the hypoalbuminemia or the weight gain, but correlated directly with the phase 2 time in a significant manner and directly with the amount of crystalloid given in the fluid uptake phase, just the opposite of what most of you here think today. At the same time, the amount of crystalloid to red cell correlated inversely in a highly significant manner with the duration of phase 2 and the amount of fluid needed during phase 2. So during the panel session a little bit ago, we heard somebody criticizing our moderator for giving 8 liters of salt solution. He didn't give enough salt solution. And this sort of belies everything that individual thinks about the effect of crystalloid solution to red cell ratio on phase 2 uptake and the duration of phase 2. Looking at this a little closer, we didn't see, as I mentioned, we didn't see a good relationship between the plasma to red cell ratio to the hypoalbuminemia. Same thing with the crystalloid to red cell ratio. But when you look at the plasma to red cell ratio, highly significant relationship to the amount of crystalloid needed during operation, or the crystalloid needed during operation and the subsequent phase 2 uptake. And with the balanced electrolyte solution to red cell ratio, just the reverse, highly significant, showing that the higher the balanced electrolyte solution to red cell ratio is the decreased amount of fluid you need during phase 2. Not quite significant for the balanced electrolyte to plasma ratio. Here we are now looking at the same thing with the phase 2 time. Increased phase 2 time with the higher plasma to red cell ratio, decreased phase 2 time with the crystalloid to red cell ratio, and here we have significance, decreased phase 2 time in the crystalloid to plasma ratio. We don't see any significance with the weight gain. Now this looks at a group of patients that we subdivided into those that had less than a 0.3 plasma to red cell ratio to those that had more than 0.45 ratio. And there is a significant difference. This should be a 75. I got an error there. This just makes significance at a 0.5 level, 0.5. And of course, this is what the groups are, so that's why that's significant. Now, when we look at the other indices of illness in these patients, we note that during phase 2A, that's the fluid mobilization phase, the first 48 hours of when the patient who has sequestered all that fluid is now getting rid of it, and we see that the PO2 ratio is significantly better in the lower ratio group than in the higher ratio group, and we see that the length of stay is significantly shorter in the lower ratio group to the higher ratio group. This is an example of the fluid crystalloid needed during phase 2, and we can see that the amount of crystalloid given in phase 2 with the lower ratio is significantly less than the crystalloid in phase 2 to the higher ratio, and again the phase 2 time is significantly lower in the patients who got the lower ratio. And these are deaths. It doesn't show any difference in the deaths. So when a little is sufficient, a lot is not always better. Everything that we give carries risk, and the treatment of the patient should be directed toward the patient's problem, not to some arbitrary ratio. And these are the recommendations I have. When you have a patient who gets severe injury and requires no more than 4 transfusions, you have adequate procoagulants in your interstitial space and you don't need any fresh frozen plasma. When you're going to start a 5th unit and you still don't have hemostasis, you ought to replace them with a 2 to 4 ratio if you have pre-thawed stuff available, and you ought to continue with the 2 to 4 ratio until you have hemostasis. Thank you for your attention.